Now that we have a good understanding of diffusion, we're going to move on into the mechanics of breathing. Basically, the lungs don't just sit there and air moves in and CO2 moves out on their own. There's actually a movable portion of this anatomy, and the physiology will come to play a big role when we get into the other PowerPoints and start talking about how all these come together and work with the movement of the lungs and the alveoli and the trachea and the epiglottis, so on and so forth. But we're going to look at the mechanics of breathing. So we know that the lungs, in order to move, they're actually inside of the thoracic cavity, right? So we know that the lungs are up against the rib cage, the ribs, right? So if you put your hands together, your right and your left hands together, and you start to rub them, moving them in opposite directions over and over and over, what happens? You build up heat in between your hands called friction, right? So when the lungs are inside of the body and they are articulating with and they are up against the rib cage, there's a covering on the lungs that prevents this friction. And that is called the pleura. So I want you guys to kind of wrap your mind around this, is that the lungs have an outer covering called the visceral pleura. It covers the lungs. And the reason it covers the lungs is it keeps the outside of the lungs very moist so that when you take a breath in and you exhale out, they can move freely up against the thoracic wall, and there is no friction between the lungs and the ribs, and you don't get what you call a pleural friction rub, which is extremely painful. So these are going to be test questions on National Registry, and there'll be test questions in your EMT book as well. You'll get a question like, what is the outer covering of the lungs? And they'll have parietal or visceral pleura. So visceral pleura is what covers the lungs. The parietal pleura is what lines the chest wall itself. So not only does the lungs have a protective covering called the visceral pleura, the thoracic cavity that lines the inside of the chest wall also has a protective covering, and it is called the parietal pleura, right? And fluid is in between both of these tissues, if you will. And look what it says. Fluid allows for smooth movement. The pleural space, right? Potential space between them, meaning they are so close together that they're almost, in a sense, not even separated. They are connected by that little bit of fluid that's between them, and that little bit of fluid is what gives the lubrication, allowing them to move in opposite directions, one from another. But because they are so close together, they almost seem connected, and it doesn't allow for any friction to take place. But let's take a look at this animation. We can see the air goes in, right? Moving all the way down into the right and left bronchi, down into the alveoli. And we can see how the lungs move inside of the chest wall, right? And when we see it moving back and forwards like that, it's very easy to understand without that visceral pleura that covers the outer lungs, or that parietal pleura that covers the inner chest wall, that these lungs would become stuck. You get a pleural friction rub and they just wouldn't function properly. Like I said, you can get a good idea if you put your two hands together and you start to rub them in the opposite direction over and over and over. They'll become very raw and very uncomfortable over a period of time. And the same thing with your lungs, it happens the same way. So, test question: what covers the outer portion of the lungs? Visceral pleura. What covers the inner thoracic wall? Parietal pleura. And what's in between both of them? We got a little bit of fluid, and it allows for what? Smooth movement, so there is no friction between the two tissues, right? and there is a potential space between them. Now, the potential space between them is very important. We're going to get into the physiology and the pathophysiology of certain trauma situations, and we'll be talking about something called pneumothorax, tension pneumothorax, and we'll be talking about hemothorax, and then the ultimate one, which is tension pneumohemothorax, which is really, really bad. But we'll talk about those later on when we get into the physiology. The visceral pleura, once again, covers the lungs. Yes, it covers the outer lungs. And I gave you another picture here because I wanted to break it down. It's very, I mean, guys, if you was doing like a lab where you could actually go in and there was a cadaver, you would have to have someone that was really good with anatomy to be able to point out, because these structures, they almost look seamless, if you will, between the visceral pleura and the parietal pleura, right? And you can see over here, I went ahead and put your diagram over here to mark them off so you can get a good idea of what they look like. I'm going to move on into the muscles used for breathing. The primary muscle, this is a test question, National Registry question, and EMT question inside of your classroom. Primary muscle, yes, is diaphragm. It contracts and relaxes to move air. So when it contracts, that is a very active process. It contracts downward, which creates a negative interthoracic pressure. That's an active process. It allows the body to pull air in. This is when the chest is taking a big inhalation and the chest wall moves up and outward and the inner chest wall becomes bigger. What happens is the pressure inside the chest becomes less than atmospheric pressure, and meaning it's negative in comparison to atmospheric pressure. And because it's a negative pressure, what happens? The inside of the thoracic cavity acts almost like a vacuum cleaner. It sucks and pulls atmosphere air, if you will, through the nasal pharynx, oral pharynx, down into the posterior larynx, down the trachea, the right and left bronchi, bronchioles, all the way down into the alveoli where gas exchange is taking place. And remember, that process of diffusion is allowing that oxygen molecule to move out of the alveoli into the vascular space. And because there's a lot of CO2 in the blood, it makes its way from the blood into the alveoli. Because remember, diffusion likes to move from an area of high concentration to an area of lower concentration. And then through that passive process, here the diaphragm relaxes, allowing the chest to return to its original size. And by returning to its original size, the pressure inside the chest now becomes greater than atmospheric pressure, and thereby it pushes that CO2 out into the atmosphere, right? That is the primary muscle for making that process happen. So, diaphragm, primary muscle, active process upon inhalation, and is a passive process up on exhalation. Now, with that said, there are other muscles along with the diaphragm that actually help us to breathe. And these are referred to as accessory muscles. Just as you would put on a really nice outfit, you put on a nice suit, or you put on a nice business attire, or maybe you and your significant other are going out on town and she puts on a nice dress and high heels. She has accessories, right? Men, we have cufflinks, so on and so forth, maybe a gold chain, a tennis bracelet. Maybe your lady partner, maybe she has a handbag and maybe she has a couple of tennis bracelet, earrings. These are accessories, meaning they add to. But the primary muscle is the diaphragm. But these accessory muscles do play a big role in carrying out gas exchange. So these are neck muscles. These are cervical muscles. These are the ones that are high up on your thoracic cavity. The intercostal muscles, these are between the ribs. And these muscles here help pull the chest up and outward. helping the individual to get air in and CO2 out. And we also have the abdominal muscles, right? And you will see these like when you start dealing with pediatrics, when we get into the pediatrics chapter and we get into where they're having respiratory issues, you'll see a lot of abdominal muscles. You'll see a lot of abdominal, they call it seesaw breathing, if you will. The muscle, chest moves out, stomach moves in, stomach's out, chest is in. You get this kind of a seesaw effect. And when you see it, you know it. You're like, oh my God, I remember Jeff talking about that. Those kids are in trouble from a respiratory standpoint. And the pectoral muscles, right? So when you get a chance, go to YouTube and just look at a few videos of individuals having problems breathing, and you can actually see these muscles in the neck, which are called your accessory cervical muscles. You can see the intercostal muscles in the ribs. You can actually see when they take a breath in, you can see in between the ribs an indentation, like the in between the ribs is almost like that area is almost caving in, if you will, almost like a dimpling effect. And when they exhale, you see it come back out and they take a breath in, you see it almost cave in again. When you see individuals have an accessory muscle use, excessive, you'll see it. It's very drastic. They're leaning forward, they're pushing their neck out, they're moving their stomach, they're moving their chest. It's very exaggerated. When you see it, you'll know it. And these are things as an EMT that are paramount, that are going to help you recognize an individual in respiratory distress. I don't even at this point in time have to pull out a stethoscope. I don't have to get a pulse oximetry. I don't need it. Do your good assessment. You can look at them and go, oh my God, they're having problems breathing. Jeff already spoke about that. That's why it's important to know the anatomy and the physiology of what's taking place. So quick recap. Muscles used for breathing. Diaphragm, it's the primary muscle. It contracts. It is a what? When it contracts, it is an active process, means it requires energy. And when it relaxes, that is an what? Passive process. That's the exhalation process, which does not require energy. And if you see an individual using accessory muscles to breathe, we know that individual is having issues with their respiratory system, meaning they cannot get good gas exchange. For some reason, they can't get oxygen in, they can't get CO2 out. And the body is doing everything it can to help this individual get better. Breathing cycles. Let's talk about the breathing cycle. Now, guys, if you haven't really dialed in yet, I want you to get you an adult beverage or maybe a cup of coffee or something good to drink, and put your seatbelt on because we're getting ready to go somewheres here, right? This is when it all gets fun. This is what makes an EMT great. Remember, we weren't called to be good. We were called to be great. And when you start understanding the anatomy, the physiology, the structures, and how things work, it's really wonderful because this is where we really start to make kind of a music, if you will, to medicine. When you start getting into the breathing cycle, we talk about inhalation, where the diaphragm and the intercostal muscles contract, the chest cavity expand and air flows, right? And we talked about that negative pressure. Remember, that's an active process. And exhalation, where the muscles relax, allowing the chest to return to its normal size. And not only is the air pushed out, it's CO2 that's pushed out. And that is a passive process. So let's take a look at this little video I'll put together for you, and you can kind of see how things are working. See how the ribs are moving in one direction and the lungs are moving up and the diaphragm is contracting and the air is moving in and out. That's the reason that visceral pleura, parietal pleura was so important, so the lungs don't become stressed out and have friction rubs. And seeing how the rib cage moves up and outward, that's the intercostal muscles working, so on and so forth. And you can see the diaphragm contracting downward, pulling the chest up and outward, creating that negative interthoracic pressure, allowing it to pull air all the way from the nasal pharynx, oral pharynx, to trachea, all the way down to the right and left bronchi, into the bronchioles, all the way down into the alveoli. Here inside the alveoli, where the O2 molecule now is a very high concentration, making its way from the alveoli under the process of diffusion into the vascular space where the red blood cell with hemoglobin actually grabs it up. Now it becomes oxyhemoglobin being taken to other parts of the body where other organs and tissues and cells can have themselves some oxygen. And the CO2 is inside the bloodstream coming back into the pulmonary system. And remember, because it's in the vascular system, the high levels of CO2, once it gets to the alveoli under the process of diffusion, is going to make their way from where? From that bloodstream into the alveoli and do the reverse in on that passive process. That CO2 is going to be exhaled back out into the atmospheric air. So let's take a look at this video one more time. This is a great video showing how the pulmonary system's working, the muscles are working, and how the ribs are coming up and outward, and understanding the parietal pleura and the visceral pleura and the diaphragm and the intercostal muscles and the neck muscles and the pectoral muscles, all for one function: to get oxygen in and CO2 out. We're going to cover the primary functions of blood supply and oxygen supply to the body. We know the primary function is to supply the body with oxygen and to remove carbon dioxide. So that's a test question. What's the primary function of the pulmonary system? To bring oxygen in and to remove carbon dioxide. And we're going to talk about two key processes called ventilation, and we're going to talk about respiration. Ventilation is the movement of air in and out of the lungs. Now, guys, can I be a little facetious? Can I go off the deep end here for a minute? If you have a person, say a cadaver, let's say we have a cadaver. This is usually somebody who has donated their body to science for study. We can actually use a bag valve mask, and we can still, even though this person is clinically and biologically dead, DEAD, we can still perform ventilation on this individual because they do it all the time in cadaver labs and advanced airway labs in medical school. You can move air into and out of it all day long, but it doesn't mean that gas exchange is taking place because this individual is DEAD. This person is dead. So I wanted to be very dramatic there because a lot of paramedics, especially paramedics, they'll use ventilation and respiration interchangeably, and the verbiage is 100% wrong. The verbiage, they're directly related and they correlate and they work together to give understanding and meaning to a process, but the words should not be used interchangeably. It ain't tomato, tomato. No, 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 no. These things are very, very different. So I'm going to cover them here. So we know that ventilation is the movement of air in and out of the lungs. Just I gave the example, you could take a cadaver and move air in and out of the lungs. But what's important, very relevant, the word respiration is the exchange of gases within the alveoli and the body's tissue. So we can move air into and out of the lungs all day long, but there has to be the process of diffusion to take place and work, meaning that oxygen that's in the alveoli under pressure, high concentration, has to make its way from the alveoli into the vascular system to be picked up by the red blood cell, which has hemoglobin, and it becomes oxyhemoglobin, and that red blood cell makes its way to the rest of the body, all the way down to your little bitty pinky toe, all the way to the tips of your finger, to the tips of your nose, supplying the body with adequate oxygenation. And through the vasculature system, the CO2 is brought from every part of the body back to the pulmonary system to be exchanged out into the alveoli. So it makes its way from where? from the vasculature into the alveoli to be exhaled. That is respiration. So let's do a quick recap. Ventilation is the movement of air into and out of the lungs. Respiration is the exchange of gases. What gases? O2 and CO2. So O2 from alveoli into bloodstream and onto the red blood cell hemoglobin, now called oxyhemoglobin, and CO2 makes its way out of the vasculature, the vascular system, into the alveoli to be exhaled. So very important you know the difference between ventilation and respiration, right? So let's take a look at it up here on this video. We can see the lungs moving in and out, seeing the diaphragm working, and that's helping to move air into and out of the lungs. That is ventilation. But let's look at this lower video. This is actually respiration. See the O2 and the CO2 making its way into and out of the space over and over. I want you to understand the difference between the two because you're going to get on an ambulance and you'll it almost is comical. These paramedics will talk about, ventilation, respiration, and respirations and ventilations, and they'll have them so confused because they don't understand the verbiage. So let's take a look again at let's go back. Let's look again at this one up here. So that's your ventilation, right? Moving air into and out of. And these are test questions. You'll see them on National Registry. I promise you. Ventilation, moving air into and out of the lungs. And here at the bottom, we see the O2 in, CO2 out. That is respiration. Exchange of gases within the alveoli and the body's tissues.